Spanish interpreter, but I supervise language services for the enterprise. So that's all of the patients who don't speak English or use sign language at Chandler, and Good Sam and the clinic. So sometimes I come and talk to doctor groups and I give them a little brief rundown, and that is what I brought you, but feel free to stop me if you have any specific questions about how to use the services or what would be appropriate or what the best options are. I always like to start with a little bit of data because most people don't realize how diverse Lexington really is. Our current estimates from LFUCG are 20% of our local population. That's a lot of people. That's like a lot. We collect data here at UK, and we get together with LFUCG, and we look at their data, and the other hospitals, and we track different language groups. So we track the different spoken languages so that we're better prepared to give you the services that you need when you see these patients. We need to know how many different languages and how we're going to provide for them. We currently track 175 different spoken languages in our area. Most people can't name 175 different languages. Like, even if you try really, really hard, I bet you could get like 40. And that number, that language diversity, that's what you would expect in a city like the size of Chicago. They have 175 different spoken languages. One of the challenges that we have is that we have 175 different languages like Chicago, but the population we have is so much smaller that we don't have the people to pull in for interpreting. So most of those languages, there's only a small little pocket of people who are not qualified to be medical interpreters. We still have to provide for their care, but we don't have a big, well-educated, diverse population of people who can be trained to actually do the interpreting. So we're stuck with super diverse population and no one really qualified to care for them on site. It's really challenging, and I know that you know that, and I don't really need to tell you because you're the ones that go into the room with the patient who speaks Kinyarwanda. And you have to do your PTOT things. I don't understand anything. Just this year to date, we've got 98 spoken languages across the enterprise, and our average is 1,400 LEP, limited English proficient, registrations a week at UK. Just for fun, I pulled some of the data for you all. I know you know that most of it's Spanish. The second biggest language, Swahili, then Nepali, then Kinyarwanda. Have you all seen these patients? Yes. Yeah, I didn't think you would be surprised. Sometimes, like new doctors, like the residents, they're like surprised. What? Kinyarwanda? Yeah. The reason we get some of these language groups, for example, Nepali, in the rest of the US, this wouldn't be the breakdown that you expect. So Spanish is big, of course, everywhere, but in other areas you're going to have different secondary and tertiary groups. A lot more Mandarin, Vietnamese, depends on where you are really, what kind of immigration they have and what kind of immigrant population. But in particular for us, we have refugees from the Democratic Republic of Congo, and the region we pull from is where we're getting Kinyarwanda, and we have refugees from Nepal and Bhutan, and that's where we're getting our Nepali population. So that's the reason we have these relatively rare language groups in such big numbers. And the French we get, which I know you all know, these are not usually people from France who speak the French. And that can also be challenging if you've dealt with it because the interpreter who speaks French might be Canadian. And the patient in the bed is not Canadian. And their French is not Canadian. And it's sometimes challenging even when you get the interpreter because there's so many different regions and so many different countries where we're pulling these language groups. Do you all have any questions about the languages you've seen? Does this pretty much match what you see for inpatients? Okay. Usually your group rehab services is one of the very best teams as far as compliance. There have been many, many occasions where we get a call from PTOT to see a patient with an interpreter, and up until that point, we didn't know that the patient was here because no one else had paged. And you all do not do intake in the ER, so it's not good. I mean, it's good that you all are calling, but it's not good that we don't know until the second or third day. There's not really any ambiguity in policy. We are required to provide qualified medical interpreters for patients and family members who do not speak English. The laws have gotten a lot more specific over the years. At first it was just a broad don't discriminate, but they get more specific, and currently don't discriminate, what that means is you have to use a medical interpreter. Does anybody have any questions about what using a medical interpreter means? Y'all are lying, but that's okay. So to meet those requirements, we have different resources across the enterprise. It really depends on where you are and what you have to do, what kind of resources are going to be the best fit. The one that everyone knows about and everyone hates is phone interpreting. Yeah, I know. It's not the best. It is kind of amazing if you think about it. I mean, you have a patient from like a remote tribe in the Congo, and in 95 seconds, you get somebody on the phone who speaks exactly their dialogue and can tell them exactly what you need to say. It's kind of amazing. But yes, I know, the blue phone, you hate it. 24/7 access through the phones is not just the blue phone. The blue phone doesn't do anything special. It is a regular landline phone. We made it blue, and it has 2 handsets. But other than that, it's just programmed with a speed dial. You can dial that speed dial from any phone. You can dial it on your cell phone and put it on speakerphone. It's programmed into the Volt phones, into the Vocera. The blue phones have their speed dial programmed in. It's nothing magical. It's just speed dial on a blue phone. We also have web-based VRI, which I know some of you have used. VRI is the exact same thing as the blue phone, only instead of a phone connection, it's a video connection. In my opinion, video is way better than phones, even though it is the same interpreter at the same call center. Having the visual connection makes many things much easier. For you all, it's obvious because you're doing the moving stuff. So obviously the visual is better. But even with just a conversation that you want to have, if you all are in the room in a pair, which you do, you do the PTOT together, you both go, and then you have the patient and a family member, and let's say, I don't know, a nurse or a kid or somebody else. The blue phone, the interpreter can't tell who's speaking to whom. When you all say things like, okay, move your leg towards me, if I'm physically there in the room, I don't say move your leg towards me because then the patient is going to kick towards me and not towards you. But I can see you. I know that what you mean is move your leg towards the window or towards the door. The phone interpreter can't see it. So even that tiny little visual connection makes the interpreting so much easier because the interpreter can tell who is speaking to whom. Is the patient asking the question, or is it the patient's wife? Are there 2 therapists in the room, both of them talking at the same time? It's much easier to tell, not that you would do that, but it's a lot easier to tell when you have that video. And that video connection is also 24/7 and enterprise-wide, but it doesn't have as many languages. It doesn't always connect as fast because there aren't as many video interpreters online. And it can be hard to use because although in theory all of the WOWs have audio and video capabilities, in practice they are not always able to do it. We also have staff interpreters, which I know you're familiar with, for Spanish and sign language and Japanese. We have contract agencies that we can schedule to come in. We have written, translated resources. If you use CRAMES, pretty much any of the patient education materials on CRAMES are available in Spanish. A lot of them are also in French and Russian and Mandarin. We have auxiliary aids that we can use in special circumstances like whiteboards for patients to write on, communication boards with pictures for nonverbal patients, TTY and Vri devices for deaf patients, which nobody uses anymore because everybody has smartphones. But we have. Any questions about what resources you have? Yes?
I'm sorry if I missed it, but did you tell us the phone number that, like if you were just put it on your cell phone, you have speakers?
I did not.
Oh.
I did not tell you because it's different for different locations. It is, there's a Chandler number, a Good Sam number, an Enterprise number, and you have to have the PIN. But I can show you where to get it. This link right here, that goes to the Interpreter Care website, and it has the 1-800 number by site.
Is it also hanging on the blue code?
Yes.
It's the phone servicing.
Yes.
So on CareWeb, the interpreter services is also where you can use the VRI.
Yes. The VRI instructions are also on CareWeb. For in-house services, which are the ones that you probably use most often, there are different pager numbers depending on where you are. So that is the pager number for Chandler Spanish, and the pager number for Good Sam Spanish, and Sign Languages Enterprise. I should know this, but do you all work weekends?
Yes.
And holidays? And like nights or just days?
Days.
Okay. So Good Sam does not have an on-site interpreter for Spanish on the weekends. Basically, we've staffed Spanish as best we can for volume. And Good Sam just doesn't have the patient volume that we have at Chandler.
Is there any way if somebody were to call ahead that there could be a Spanish interpreter available at Good Sam for a short period of time on the weekends?
Yes.
Because sometimes we have orthopedic patients that we have to see twice a day and they speak only Spanish,
Yes.
and then we aren't able to talk to them well.
Yes.
Okay.
Ideally, you would request it like before noon on Friday, so we could schedule it. We can schedule Spanish for the weekends. We can schedule Arabic, Swahili, French, Russian, Nepali, all of our big languages if we can try to schedule them in advance. We can definitely schedule Spanish on the weekends, but also if you have a complex patient who speaks Arabic or Russian, we can schedule that on a Thursday.
Sure. So how would we do that? Would we just contact your office or?
Yes.
Okay,
My information is the last slide.
great.
Okay. I put some frequently asked questions. These are the frequently asked questions that I get from doctors and residents. Yeah. So the most common one is, can I use the family member? And it always is followed with, but they really don't mind. And I don't have anything to say except, no, you can't. Not ever can you use a child. Ever, 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 ever. It is prohibited by federal law. So it's like not, like, I can't, like it's not, I don't get a vote. I did not write the law. It is there, it is in black and white, There is no reason we should be using a child at all. Also, if you speak some Spanish, that's nice, and I am happy for you. The law requires you to use a qualified medical interpreter. The law does not give me a list of different things that you might not need an interpreter for, like, what if I just need to ask if she's cold and can I take her blood pressure? Like, the law just says it. So the only answer I can give you is you have to use a medical interpreter. And I understand that sometimes it's easier to just use the motions, but my job is to give you the resources to be compliant. And compliant would be, you gotta use a medical interpreter. Yes?
The nurse is required the same thing.
Yes.
So if the patient wants to go to the bathroom, you need an interpreter there.
The law says we're required to use medical interpreters. It usually comes down to what would be the issue if you didn't. The concerns that I usually want to bring up when people tell me that it's just a minor communication, probably going to the bathroom is fine. But if you're doing something quick, like a blood pressure, and your English-speaking patient would want to know, for example, is my blood pressure getting higher, or is that why I feel lightheaded? And because you didn't get an interpreter, then your Swahili-speaking patient doesn't have an opportunity to ask questions or communicate or voice pain. That's why the rule is there. And I mean, yeah, I know, it seems really silly. But the law doesn't give me like a list of every single circumstance and the exceptions. It's just the law. So I can't really waive it. It sometimes is a judgment call, but I would always put yourself in the shoes of that patient. What if it's me? What if the blood pressure cuff hurts my arm and I want to know if it's too high, if I should be taking my meds, if I'm cold? We want our patients to have the same opportunity to communicate that an English-speaking patient will.
Are they allowed to decline the need for interpreters?
Yes.
And do we need to document that in any way
Yes.
especially?
There is a waiver form if the patient decides to waive interpreting services. The caveat with the waiver is the patient can waive the legal requirements that we have to provide an interpreter, a medical interpreter. The patients cannot waive liability. So if your care is compromised by a lack of understanding, you need to use a medical interpreter anyway. And we have had that come up with patients who think that their own English, that they're bilingual, but then the doctor can't understand what they're saying. And we just try to explain to them very politely, you're totally right, we understand that you don't need an interpreter, but we need it just for us.
That was kind of my question. We have many patients who their primary language is Spanish, but they can communicate through very basic English, and we have to get a Spanish interpreter, even though we're both speaking in English?
Unless they waive, yes, unless they decline. The obligation under the law is on us to make the services actively available. I don't know if any of you have seen like the posters and the little signs that are in the clinic entrances. Even on our like HIPAA forms it says, you know, interpreting services. That's because the obligation, the burden, is on us as the provider to actively offer services. So if the services are then declined, we would want to document that they refuse it.
Does it have to be the patient who does the declining versus family? Well, we had an ethical situation with the husband refused us to give an interpreter because he did not want the patient to know what's wrong with her.
No. No. No.
Yeah, that did happen.
We ended up calling.
No, I believe you. No.
We called ethics and they told us we needed the interpreter regardless of what the husband said.
Yeah, he doesn't get a vote.
So what if the patient can or can't not agree? Because of
Power of attorney or capacity?
capacity in that moment.
The same as if it were an English-speaking patient without capacity. The person
family.
yeah, then, yes. Yes.
What's the best approach, like, if it's not one of the main languages that have on-site interpreters for patients who have like poor vocal quality or they're very hard of hearing?
I would use the video and also ask the patient what the best way to communicate is. If they say that they would, like with the interpreter, we're going to do exercises, what's the best way for you to understand this? If they say, just motion to me, like do the signals, do that. If they say, I want to write it down, they can probably write it down and show it to the video interpreter. I would ask the patient. Most of the time, the patients are really the best guide for how we're going to be able to do this well. Yes?
There's a waiver sign in the ER, does that go in a paper chart, or is there actually something in the, that would indicate that?
It is a paper, it's a paper form that would get scanned in.
And then that covers the whole hospitalization?
It depends, it's got active dates on it. It does not cover them after discharge, but some of them sign a waiver for a specific date or a specific event, and some of them sign it for the entire admission. Translation apps, where you type it into your phone, don't do that. Just don't do that. That's not compliant under the federal law. And again, I realize that it seems like it's going to be a lot easier and a lot faster. The reason the translation apps are not allowable is that they're not qualified translators or qualified interpreters. It's not a live person. So there's a lot of things that can get mistranslated without the context or without the background knowledge. Just like a super simple example, our weekend interpreter at Chandler, who works in the ER, Elliot, super nice, very good. He went to discharge one of his peds patients a while back, and the resident, with great intentions and a very good heart, had copied his discharge summary, pasted it into Google Translate, and printed it out for the family. Which again, super nice. Except that it was a little girl with a urinary tract infection, and the printed out instructions were telling the father to bring her back to the United Kingdom for erectile dysfunction follow-up. And Elliot's like, what are you trying? What do you think you're saying? He wanted to say that you need to come back to the UK ED for follow-up if the symptoms don't improve. And Google Translate thinks that UK is United Kingdom and ED is erectile dysfunction, and just don't do that. Don't do it. Just don't. Yeah.
We had a patient recently who the family provided a small handheld device, and when I spoke in English, it printed out what I said, and it was accurate. I could check to see if it was accurate. When he spoke in Mandarin, it printed out in Mandarin. We could see what it was saying, so he could check and see. We could also see underneath the Mandarin what was in English. And the family said they did not want an interpreter, that they wanted to use that device. So I just documented, I didn't get a waiver because I didn't know there was a waiver, but I just documented that per patient and family, they chose not to use an interpreter. But as far as that device goes, since you can say that it's 100% accurate, they still need to sign the waiver, I'm
Yeah.
sure.
I would get them to sign the
As far
waiver.
as the waiver goes, is that something that we can just have and have someone sign, or is that something that social services or someone needs to do?
Anybody can get it signed. It's on the medical records form site and on CareWeb, just like all the other consent forms
Finding
and
it there on the form site. What's it labeled as? We couldn't find it there.
interpreter waiver.
So you have to go to medical records.
It's in-
Records tab, or the interpreter tab. And you don't care about the grade, it is.
Yeah, that's true. Do you want me to like send you the
Screenshots weird.
Yeah, okay, I can do that.
You made it sound.
Yeah.
They have an interpreter
Yeah.
the waiver
Yes.
form, correct?
Yes, they do.
The interpreter has to be.
Did you all hear that part?
I think we're,
The waiver form, I know, this is not popular, and I don't have a way to make it better. The waiver has to be signed with an interpreter, which I know, like I have to give the same presentation to doctors, like I know how much you hate me right now. But there's really nothing I can do about it because the idea is that we have the obligation to inform the patient that we're giving them interpreters. So if they don't want it, how do we document that they understood that we'll give it to them for free? Unless we use the interpreter to get the waiver. I'm sorry.
if it says there's a language that isn't, we can only use the phone for,
Yeah.
can describe the waiver to them?
Legally, under the law, there is no difference between a staff interpreter and a phone interpreter. Our contracts are very specific for medical interpreters, and every interpreter, whether it's a contract staff person we're calling in on the weekends, or whether it's staff, or whether it's phone, or whether it's video, everyone under UK meets all of the qualifications for medical interpreter. And in the eyes of the law, they are all equal services.
So, I understand if a patient refuses interpreter, but when we use an interpreter, as far as I know, there's no clear place where we all put that or what wording we use, so.
It is in the standard document, it is, in our standards of documentation, it's a clear spot on where to put that. It's in that document. in our
Well,
department.
see, I missed that, and I've talked to several other staff members, and we all were a little bit unclear on that.
Our new
So
EMR
we're
is
not
gonna
gonna
fix
fix
all
the
that, so don't worry.
documentation then.
Don't worry, we're getting a new EMR, it's gonna be great. I would document it when you use an interpreter, when the patient declines an interpreter.
Apparently, I missed that, so I will refer back to my notes. We don't memorize the whole thing. Yeah, nobody here knows what it is.
So that's
Even
an
if you're
internal
just-
thing that we need to fix.
Even if you're just writing it in your note via interpreter, use phone interpreter, just 2 little words, that'll be good. The other question we get a lot, bilingual nurses or doctors or staff. There are guidelines for bilingual staff to provide care. They must have documented language proficiency. And they are not allowed to interpret. So what that means is if the nurse, or let's say the transplant doctor, just hypothetically, let's say he's from Venezuela and speaks Spanish.
It's not hypothetical.
I know. So that doctor has documented language proficiency because he has all of his medical degrees from Venezuela, which we consider documented language proficiency. The fact that he has higher education diplomas in the country, the language is spoken, is valid as documentation. He can do all of his job with that patient. He can consent them and take their liver out and give them new livers, all of that in Spanish. Cool. Same goes for any other, if you are from China and your higher education was done there and you have a diploma, fine. You can do your Mandarin patients, you can do all the PT and the OT and the moving of the arms, great. Interpreting is a separate qualification. So what is not allowed is for the transplant doctor to come in and tell the patient what the neuroconsult doctor is saying. So whatever your job is, whatever the scope of your role is, you can do all of that in 2 languages or 3, or 4, as many as you want, if you have documented language proficiency. But you can't step outside of your role and translate for somebody else. Does anybody have any questions about that piece?
So if we have some native speakers, but they got their higher education here in the United States, they cannot interpret for themselves.
No. They can get That's a very good question, and it comes up a lot, actually. They can get documented language proficiency by taking an assessment. It's very simple. It's an oral assessment. It can be done over the phone, and our department will pay for it. So if you are bilingual and you don't have like a diploma from the country the language is spoken, if you email me, I will get the assessment. It has to be a third party. It's not like me personally. I'm gonna go.
So we had a patient the other day, and the interpreter over that saw him with us said that he was bilingual. Said that the patient was bilingual.
Okay.
So he told us that we didn't, of course, they need to have him there or use one call or whatever for every little thing. Now, things that were immensely complicated, he said, yes, absolutely have him there, but like basic things, he said he understood, and he's given here to understand everything that we were saying before he even got the interpreter could interpret. He was already answering questions and things like that.
If the patient is voicing that they don't need an interpreter or they're declining for part of an assessment, you can document that as that they're leaving. But none of us, not even an interpreter, can waive a patient's right to an interpreter. Even if, and we do have patients, we had one, God love his little heart. He was from Egypt and his primary language, in my opinion, was Arabic, but he wanted a Spanish interpreter. So we interpreted, even though he had this accent. I know, it's Moroccan Arabic, but it is the patient's right. Any other questions? Yes.
What is the etiquette? Like, do we, when we're having a interpreter with us in the room, like, do we just talk to the patient and let them interpret? Or
That's such a good
do we
question.
talk
Nobody
to
ever
the
asked that.
interpreter?
Yes.
Yeah.
Ignore the interpreter completely. Pretend that we don't exist. We are nothing. Talk directly to your patient in the first person. Look at them directly. Act like the interpreter isn't there. Our professional ethics are technically to interpret in the first person, which means that if I'm doing my job correctly, I should be saying, when I'm interpreting for the patient, when I'm voicing, I should be saying I. My leg hurts, I can't move to the right, I can't feel my head, I should be saying it like that. Sometimes with you all, we don't do that because it's too confusing, because there's two of you and you keep saying things like move towards me. And if I do that in the first person, then the patient literally moves towards me, the interpreter. But yes, you should ignore the interpreter completely and talk directly to your patient, look at your patient, make eye contact with your patient. Other questions? So that first link there is the CARE website for interpreters. So it has things like the 1-800 numbers, how to get on a VRI, the different pagers for the staff interpreters, my contact information. And then the bottom link is the final rulings on the federal laws and regulations, which I know you all wanted. And then, I hope I'm not running too late. Am I running late? I'm running way late. All right. This is a VRI device that I think some of you might have seen. Has anybody seen this? Y'all know what this is? Okay, it does the same video thing that you can do on a WOW, but it's just for video interpreting. So it has like a little tile screen, and it connects to a video interpreter. It has all the same languages that you can do on the blue phone, but it has it on video. So you scroll down and tap it, and it's movable, so you can move it towards the patient and adjust it. Huh?
I was gonna say, are they at Sam's?
There are some at Chandler and fewer at Good Sam, but here's what I wanted to tell you. This one is for PTOT at Good Sam.
Oh,
It's yours, and it's a present, and I have one for Chandler too, only they're heavy and I didn't bring it over here with me. but if somebody from Chandler will get it,
Yes.
I will deliver it to you. This is yours, and there's a catch.
There's a catch.
There's always a catch.
Well, I got an idea when you invited me to the meeting, and I started thinking, rehab services are always so good about using interpreters. Like I was saying before, sometimes there's a patient who's here for like 3 days and nobody calls, and then you all call. What if you had these, and then when you go up to the floor to work with the patient, and the nurses are like, wow, where'd you get that? And then they want it, and then they demand it, and then I get more money to buy it.
Just use it, Sarah. Use it.
I am, I'm so sorry, I have no shame. It's a Trojan horse. So my idea is if you have it, then everyone will see it and want it, and I will be able to get more of them. Because I want one for every patient.
We have one for Chandler.
Yes, rehab services. You all have one for Good Sam and one for Chandler.
So do we have a conversation about the intent of this? Is the intent still of a local person in the regular
Okay, I would still personally rather have a staff interpreter interpreting because I think it's better communication, but all of you know that sometimes you page and the Spanish interpreter is like, well, it'll be 20 minutes, or it'll be half an hour, or when do you want to see him, or if the option is not seeing your patient or using video, use video. In the eyes of the law, this is equally compliant. I just think, you all know, it's easier with an in-person interview. So the idea is really to replace the blue phone, not replace the staff. I just wanted to, yeah, also. Okay, any other questions? Because I used way too much time and I'm sorry. Thank you. You're very welcome. Is the top